know Michelle mentioned p-tau a number of times, and to talk more about p-tau, the very pioneer who was instrumental in developing the assay. So it's a great honor and pleasure to welcome Dr. Thomas Karikari, who is an assistant professor at the University of Gothenburg and the University of Pittsburgh. His research aims to further understand the molecular and biochemical basis of pathological brain changes that occur in Alzheimer's patients, and to apply this knowledge to develop new biofluid-based diagnostic tools for clinical use. As a postdoctoral scholar at the University of Gothenburg, Dr. Karikari developed the most widely used and reliable blood test for Alzheimer's disease to date, which reliably quantifies blood p-tau across all age groups to enable diagnosis and prognosis. He has received major scientific awards for his discovery and development, blood biomarkers. Currently, he serves as the director of the mass spectrometry and the Simoa biomarkers program at the University of Pittsburgh, and collaborates with multiple investigators and leads the fluid biomarkers core of the NIA Alzheimer's program project grant. It's an honor to welcome.
So I had a cold, so sorry for my awesome voice. So it's very difficult to really follow up with the accent here that Michelle has put up. But I'm just going to continue with, now that we are looking at the clinical use of these markers, even in terms of, anti-amyloid therapies that are already being used in clinics.
Yes.
And we want to start using these markers so they're actually being used. What are some of the key things that we have to think about and we have to consider? If you mind disclosure, just to say, all I'm going to say, because there's no industry linkage, so I guess I'm at liberty to say what I am to say. There's been a lot of changes that's happened. So, for example, this is the and I do remember this was actually in 2019. This was the very first data I personally collected on plasma phospho-tau 181. And I was sorry later when I was able to make it work again. But since that time, where this paper was published in 2020, from that time to today, there's been an accelerated progress, like massive changes that's happened. I think that was really well captured by this commentary that Cliff Jack wrote in that article about the transformative potential of plasma processors, probably let's say plasma biomarkers. We expect an uptake in how they're going to really be applied, but we really didn't expect it to be this much. So we've all been surprised in a positive way. But then with the increased uptake, we need to also be mindful of some of the things that we have to So for example, this was a review that we published last year, where we tried to work out all the assays that were available at that time. And there's a massive amount. Actually, there's more that has been added. If you like that, if you do another review, we would be adding more. Basically, there are a lot more assays that are now available, both from academic labs and also from industry partners. In a way to say that there's a lot of confirmation or collaboratory findings from multiple places. So what are some of the things that we should really be aware of now that we are transitioning from lab-based developments to clinical applications? And one of the things I would like to talk about is, first, we should know our population. What population are we using the markers of is extremely important. The reason being that we've done a lot of our research on populations that already have CSF and OPEC measures, people who have been extremely well characterized. We know them inside out. And then once we do that, what gets to happen is, So what gets to happen is that we have what I call this circularity, because we know a lot of phenotypes, about these individuals. We know their brain imaging features. Some do have all the three amyloid tau neurodegeneration features. They have CSF. Some even have other omics data. And then we turn around and we use the blood markers on these same individuals. And we say, look how awesome the blood markers are. And in one of the native languages in Ghana that I do speak, they have that it's like defeathering a bird and bringing the bird to an elder and asking them, what kind of bird is this? You know the bird, but you just want to trick someone to try and tell you what it is. And that's one we're going through. Now, it's not, it's a partial criticism, Because when you start with a new marker, when you develop anything new, when you want to publish in a top journal, you need to show that the marker is giving you what you want to see. Now, to be able to do that, you need cohorts that have all the awesome characterizations that are possible. Reviewers want you to show them from the ground to the heavens that your marker is doing what it's supposed to do. If you don't have these well-characterized cohorts, you cannot do that. But at the same time, having done that, these well-characterized cohorts also have the limitation that there's inside out, these individuals, right? One of the things that Michelle was talking about was that comorbidities. Key thing is that there's been also like backup for where some of the cohorts, some of the studies were like, oh, we don't see comorbidities in our cohort. As I said, we see like the association with comorbidities. And when this discussion came up, my point was like, well, have you forgotten how your inclusion criteria was? Just go back and look at your inclusion criteria. In none of these prominent studies, the inclusion criteria, you cannot have anyone who's had any brain trauma of any kind, diabetes, who had like all kinds of things. So you weed out all these people and you go with the pristine individuals and you run your studies on them, and you see awesome results. And then you say, well, we don't see the association with the bad things. Well, because you weeded them out from the beginning. If you kept them out the door, they couldn't be in. But now when we start looking at a lot more community studies, that's when we see these effects. And this is what we play out in the clinic, because that selection is not going to be there. So for example, we know we've seen like a lot of awesome associations between plasma phosphatase, more especially like phosphatase 317, and the ability to tell you more about amyloid pathology in individuals. So we are looking at what does it look like in the community. And here we're focusing on the predictive value. So negative predictive value, where the test is going to tell you whether someone has amyloid pathology or not, and positive, where the test tells you whether they have or not. Now we looked at these were 2 cohorts, and we've actually gone ahead to do 4 cohorts now. And we looked at 5 different tests. Now we look at 6 extra data. And these are community cohorts. So individuals, including those who have were research naive, up to high school education. And what we see is that the negative predictive value is close to 1, right? So let's say 90%. So it means in the community, these tests, all these 5 hospital tests are able to tell you that someone does not have amyloid beta pathology by comparing with the A-beta, right? With a very good performance. But when it comes to telling you that someone has a disease, that is when the struggle comes in. They don't even tell you about 50%. And it's one of the things we have to think about when we look at the clinical applications of this. And personally, it's not surprising. The reason being that in the population, the percentage of individuals with amyloid pathology is way smaller. And 2, even if there are, the level of pathology will be much less, because they haven't shown any cognitive signs that would prompt them to see medical attention. So you're dealing with people who are really at the bottom of the spectrum, showing very subtle signs that likely we're able to see in the brain, and then the blood tests are picking up. But then to be able to say that individual has these tests are not good. Now, interestingly, when we're focusing on AUC, so area under care, we're seeing 91% for all these tests, over 90%. So the tests are good, but then to tell you an individual whether someone has a disease or not in the community, where your prevalence is way lower than the average population you've been looking at, there is a problem. And that's one of the things we have to look at. And this is what I try to illustrate that. For example, when we look at the plasma phosphatase, and it's like almost all the time is what we see. Individuals who do not have amyloid beta pathology have very low levels. Individuals who are cognitively normal also have very low levels. And these are the people that mostly potentially you would find in the community. Those who have mild cognitive impairment and then Alzheimer's dementia have way higher levels, because there's a spectrum that goes on. And those are the people that we would not mostly find in these population-based cohorts or in the wider community. And by extension, in the primary care, if we're going to apply these tests. And these are things that we have to be worried about. Because if you just focus on the bottom here, then your test doesn't have the range, the margin of high values to tell you, to give you the positivity measures. And the second point is blood enough. We're really excited about blood tests, but we just also want to be real in some sense. And there's some situations that we might want to confirm with PETs. That, for example, now we're saying, like with the update the pending updates of the framework that we already talked about, talking about now AT-MIVS, where we actually see a pattern of imaging, CSF, and blood. They really put at the same level. So are they going to be used interchangeably, or could we choose one and over the others? Are we saying they obviously have the same pecking order? Now, one of the things we've often seen is that, and that's also like that comes up in the news, is that, well, these blood tests are as good as imaging, as CSF. You don't need any of those anymore. Maybe true, maybe not fully. That, for example, I just showed this figure that basically shows like A uses of 99, 90%, when you focus on plasma biomarkers compared with CSF. Now let's focus on what populations are we comparing. The comparison was between those who are amyloid negative, non-Alzheimer pathology, again, those who are amyloid positive, Alzheimer dementia pathology. So, like the slide I showed you previously, you're talking about the two spectrums, like the two ends of that spectrum. So, for example, these individuals here compared with those ones there. So that's going to do really well. But the problem mostly might come up in the clinical population for the individuals who might be in that gray zone, those who have heterogeneous presentations, those whose A-beta positivity is not really clear, like in the gray zone, and then also so like might also be contributed by other factors like several angiopathy, different kind of things. Those kind of things we see in focusing on CSF tests, because even the clinic CSF tests are not even the most easiest to apply, and we're going to see probably even worse with plasma, and that's one thing that we need to be wary about. So, common comorbidities, something that probably actually jumped because we have already talked about. There are a lot of things that we need to understand. Our studies are focused on what I call probably the geriatric population, that looking at the individuals at the like over 60 years and above. But then one thing we need to understand that all these markers we are focusing on, they are not pathophysiological markers. They are proteins that actually have physiological functions. And it's when things go wrong that there's a shift. So we need to understand much better their physiological functions and how that tips them over. Like, for example, when you look at tau, and I didn't show that here, tau protein has like a U shape, that in individuals like very, very early of development, there's a massive increase in these phosphorylation sites, because that's where they're helping to form all these, and I stabilize all the axons, that's where the normal function. And interestingly, they go down with time, and like about probably like 5 to 10 years of age, some of those sites don't see them again until at the later side with age a little bit comes up. But when the disease tips in, that's when they go back up massively. And we need to understand those so that we don't start to apply these tests that, someone 30 years, 20 years comes up and said, they have high levels of this marker, it's Alzheimer's. Well, no, because unless it's like really early onset Alzheimer's, now we need to look at the full picture. Biological factors that are some of those that Michelle talked about, so I won't go into it. For example, with kidney function that Michelle talked about, here we looked at individuals who had the same population, impaired EGFR, and those who had normal EGFR. Now, when you have the EGFR is normal, and these are not individuals who have CKD, they just have abnormal EGFR. So like they wouldn't classify as patients with chronic kidney disease, but they just sort of on their way. See that the performance of the tests are better in that. And personally, I haven't been surprised about these findings because it's something I predicted way back from 2020 that, and the reason being that if you're looking at blood, I look at it as an analog mixture. It's everything we see. Our interest is that we think that we would like to see whatever we find in these blood markers will come from the brain. But we should also remember that the blood is a collection of everything that from the body, from diverse sources that we cannot control. And knowing that some of these proteins, for example, tau is highly expressed in kidney, liver, heart, quite close to high level they expressed in the brain, these are going to be troubles that we have to look at. And we'll be working on trying to address them, something I'll talk about a little bit later. And in that sense, blood marker changes do not always mean Alzheimer's disease. And I just selected a few examples to show. Here, for example, these are individuals with traumatic brain injury. And here, we're looking at brain-derived tau, one of the new markers that we talked about recently. And look at the changes. At day 0, look at the level. And at day 365, a year later, look at the level. So apparently, the levels are really hovering around where the 3651 is. But just on within 2 hours that individual developed TBI, there's a massive increase. And this is not something specific to brain-derived tau. We've seen that phospho-tau, Q17, all the markers. And the way I think of it is that it's like a tsunami happening. Your house is not going to be spared. No matter how you cannot say that my house is specific for something and you're going to be spared when there's a tsunami. No. Everything's going to be affected. And because there's that direct release into the blood-brain barrier, within hours, you see these changes in the blood. And that they will be useful for prognosis. But we do not also know, for example, here we don't have a control population. And in most of these ones, because you don't know who's going to develop TBI, which is that following that. We don't know what is the baseline. So we also don't know when they actually come back to baseline. Is it a year later? Is it 2 years later? Is it 3 years later? And within that period, if you're looking at these individuals for Alzheimer's, you're considering them for Alzheimer's, how are you going to factor these ones in? Are these levels going to contribute to what we think we'll see? Same with NFL and others. So we try to look at these like in much closer detail. So for example, we look at traumatic brain injury. What we see here, we looked at a population that has like shock and non-shock. So we had a healthy population here as a comparison to the ones in green. Now, over 10 days that these individuals were followed. So on the 0 day of day 1, 0 hours, those who had a shock together with the TBI had higher levels. And this is a log scale percent. Had higher levels compared to those who did not have shock. And that it continued over the days where there was a drop over time. But 10 days later, you'd appreciate that the levels are nowhere close to those who were unaffected about age-matched controls. And that's like this sort of a simulation, like, at 10 days, you have the green. We don't know how long it's going to take to get to the green for these individuals to come out to the green. Now, we have got this brain-derived tau like is a marker that we want as like to be specific for the tau isoforms that we think are most highly expressed in the brain, selecting out those that are not expressed in the brain by expressing the periphery. So we got this new marker that is more tau from the periphery, the isoforms of the periphery. And we measure that in the same population, squeaky clean. There's no difference compared with those who are healthy. So probably arguing here that when traumatic brain injury happens, the changes we are seeing that contribute to all the tau measures we see are directly coming from the brain. That is at least in a good way that we can start to say to be sure that this is what the focus is. The only exception was in a subset that reported having chest injury together with the TBI. And the reason was that there's a high expression of peripheral tau in the heart. Right? This is sort of that I won't go into details. How are we going to be inclusive with the couplet? Now, the way we present, or the way it's been like with these blood markers that we have it all figured out, we actually don't even know what cut points we have. And we've been looking at cut points from a few studies. Some of the studies have started talking about this, but they don't stay. Like when you compare with others, they're not stable and they haven't been looked at by well. And how are we going to be inclusive in this? There are a lot of factors to look at. A lot of those have been looked at. For example, we did a study a couple of years back where there was a selection. So this was individuals in St. Louis. I did that with Susan Schindler, where there was a pairing. Because the argument was that, if ApoE has effect, you don't have effect. Let's select African Americans and non-Hispanic whites that are paired for their ApoE genotype, for their cognition, for their age, for their sex. Are we going to see things that are the same, or are we going to see differences? And basically what we see here is that there's subtle differences. So for example, if you look at A beta, look at the A beta ratio, like the CSF, you're going to add that. The mean levels where the bars are quite different. And they cut across, if you see that for plasma A beta also. Amyloid PET is a reverse, where in the non-Hispanic ones, like the mean level is a little bit higher compared with the African Americans. And then we saw the same for the other markers. Mind you that these are individuals who are paired otherwise for everything. So if these are showing some of these kind of differences, then I estimate like about 10 to 15% difference like in the level. So if my own pair, there are up to 15% differences in the levels, like the concentration that would be reported. If this is an issue, which I think I'm personally beginning to appreciate that could be an issue because there are a lot of studies that have been showing this, and even now some new pathology studies have been showing the same, that if you go to people like high African ancestry, like in Brazil, for example, those individuals show low levels of these amyloid pathology, even at autopsy. And they focus on those who are like somewhat pure Alzheimer's. And it's something that we have to look at. Personally, I think that this might not be something really unique to such populations. That when we start to look at populations that are, for lack of a better word, less clean, then we might start seeing these issues. Because as I said, it's actually showing that we think it's Alzheimer's, amyloid, tau, neurodegeneration. Some are showing it from like Hispanic populations that you have neurodegeneration, you have vascular, and that is what tips you to amyloid. So like there's sort of, it's not as clear cut as we may think based on the studies that we have looked at. Now, could we use these markers for eligibility for approved therapies? We looked at a clinical trial that had happened recently in Pittsburgh. So this was about 76 individuals that were included in the clinical trial, small clinical trial, and they used amyloid PET as inclusion, but they collected them. So we did a measurement recently, and then this was first of 2017. And what we see, really beautiful, right? It tells us that those who are A-beta PET positive have high levels of the marker, those who are negative at low levels. So if you somewhat put a line through it, you see like there are two individuals on either side that are mismatched. Now, this is so good because even we know that changes appear much quicker in blood or earlier in blood or in biofluids because they're more soluble forms of these biochemical pools compared with when you're looking at imaging, which is more about the aggregates that take longer to form for these ligands to be able to sensitively tell them. So those individuals who are showing high levels but showing A-beta PET negative could actually be individuals who have high levels of the pathology, but then they're yet to be shown by PET. We've seen this multiple times where if you follow them up, then they might show increases 2 years later, for example. For amyloid PET negative individuals, so those two people who are amyloid PET positive but phospho-tau negative as the ones that I would call like more concerning, because are they like poor producers of A-beta, or are these individuals where there's some comorbidities, anything that really is not matching properly? And these are things we have to look at. Now, this doesn't match what I talked about initially, because this was focusing on patients who had MCI. So it means they're much closer to the other end of the spectrum, where they tend to be telling you much more about the positivity. So we have already started reading about that these clinical strengths is really being stretched because we have a large proportion of patients who qualify for these recently approved therapies, but how are we going to be able to really meet everyone's demand? And at present, the focus is that individuals should be amyloid positive, and then they should also be impaired as well as clinical population. And aside all the few other things like APOE and all. Now, imagine there are going to be like thousands of people who would qualify for the therapies. So the question becomes, could we think of a way that we could prioritize some people for the therapies among those that do qualify? Because maybe they're going to have a rapid disease course or something of that kind, we don't know. So we'll be playing with this approach. We say, when we go back to 2011, the then NIA framework that published at that time was talking about this approach. When they were more focused on preclinical, but then I think it applies everywhere. Where the approach was that individuals who become first amyloid positive, and that amyloid positivity sort of tips them over to also develop neurodegeneration, and that is what really pushes them down the cliff. Now, in that sense, it means if you're using A, which is amyloid positivity, and N, neurodegeneration, then that should provide you a clue where A is those who are amyloid positive, and N is really telling you who's likely to go down the route of cognitive decline, rapid cognitive decline. So we played with that approach using plasma brain-derived tau, which we have shown as a neurodegeneration marker. There's actually a follow-up paper that tells us a lot more in detail, and that has just been accepted last week. And so we look at the plasma area. So A is phospho-tau, N is brain-derived tau, which we're trying to be more neurodegeneration specific to Alzheimer's, and unlike NFL. And this is what we see. We focus on a mostly preclinical cohort, which is DDI, in a region cohort. And then we also had Biodigma, which is a memory clinic cohort from Spain. So this is quite a very European study. Now, in the more preclinical cohort, what we see is that based on these plasma combinations, the AN, at baseline, and also up to 8 years follow-up, it's only individuals who were amyloid positive and neurodegeneration positive based on plasma markers for Alzheimer's that had significant a likelihood to decline further on the cerebral recall test and also on the TMTV. But not just these. When we focus on the AD-MEPARA, which is the neurodegeneration structural MRI signature shown to be more specific to Alzheimer's, we saw the same thing. So it's more like validating what we had really predicted initially. And we see similarly in the memory clinic cohort, where you see more individuals who are positive for amyloid and neurodegeneration, so phospho-tau and PD-tau that really tipping them over in a way. So potentially, this could be a way that we could, be able to work out who should be put up first for therapies because the likelihood of a rapid cognitive decline or also neurodegenerative changes as well. And how do we monitor adverse effects? This is going to be really big because at present we don't have ways to do that. Well, you have to go through MRI, repeated MRI, and you need a specialist to be able to read those MRIs because that's not even just any radiologist to be able to do that. Wouldn't it be nice if we had some lab tests to do them? And that's what we've been working on. But one thing we have always been, the challenge we've had is companies are not ready to release, even the trial that have been closed, to release the samples to you to run them because they don't like potential negative press. So we've been going around, and what we did recently was to look at ischemic stroke. We know it's not the same, but there's some similarities. And here, for example, what we see is that based on brain-derived, because we see that it's a neurodegeneration marker or more related to Alzheimer's. In that same way, then it should tell you more about features that are very much what you might see in Alzheimer's and potentially when you have these safety concerns. That from the levels of the change from time of onset of the stroke attack, really correlating with the impact volume. The higher your impact volume, the higher the levels. And look at the levels over time. You go up within like a few hours and they stay stable for quite some time, more or less. And the association with the impact size is pretty well there. And it's important to really telling you about clinical outcome was much, much higher compared with even the carbon, the aspect that stroke aspect we use a lot. Now, we know that if we go a step further, or if you look at NFL, in that same subpopulation, it's more, all over the place. So telling you that NFL really doesn't, and we should look for GFAP and other things. More recently, we've looked at intracerebral hemorrhage. Maybe that's closer. So we're getting closer. And we see more the same, there's a good association with the hematoma volume, and also in terms of the importance in really telling you see the better importance over GFAP, for example, that has been used quite much clearly. So I'm going to end out here and say we've seen really good performances of blood markers. We are always excited about them. We just want to be able to make sure that when we go to the clinic, we're not going to look at these group sizes. We cannot correct for things by statistical modeling. We have to correct by the individual, and we have to be able at that point that we can do it on that level. Thank you very much.
Thank you so much. Maybe we'll take one question.
So it's kind of a question for maybe both Tommy and Michelle. I'd love to just get your comments on this. So I feel like one of the things that we are challenged by when we talk about diagnostic tests, and particularly diagnostic tests that then would be available to the masses through blood tests, is that normally when we think about diagnostic tests, we think that everybody is agreeing on what the disease is that we're hoping the test will pick up. And I think one of the real challenges in our field that may be less appreciated by some members of the audience than others is that we've had this really kind of sea change and evolving paradigm shift in how people think the disease should be defined and diagnosed. And that's, it's kind of moved for many of us from a clinical syndrome of symptoms to a biopathological diagnosis. And there's now kind of disagreement in the field about whether that's an entirely okay thing to take people who are cognitively unimpaired and say they have Alzheimer's disease. But even if we stick within those people who say, yes, I'm down with the biopathologically defined diagnosis of Alzheimer's disease, I think that it may be a moving target for us over the next few years in our field as we understand the mechanism better and perhaps find out that actually Alzheimer's disease is there way before the amyloid and tau, and people actually have Alzheimer's disease even when they're amyloid and tau negative in their brain and they're on a path to one day become so. So I guess my question is, number one, like, how do we reckon with this when, should those who are developing the blood-based biomarkers just be very, very clear on what the sort of reference standard and how you're defining the thing that you're trying to recognize? And then how do we account for this idea that if we're gearing them now toward how do they detect brain amyloid by PET and CSF? And if in the future we begin to understand that that's even a later phase in the disease and the disease is there before those changes are there. You understand what I'm getting at?
Yeah, I think it's a great question. And really, if you think about the development of blood-based biomarkers too, that was really around thinking about disease-modifying therapies. And first disease-modifying therapies were amyloid, right? And so neither Tommy or I really talked about it, but actually p-tau early on is a better marker of amyloid pathology than it is of tau pathology.
Mm-hmm.
And so we're very geared towards that at this point. Right. And so what does it mean then when you've got disease-modifying therapies that are tau-based or, some of these other factors or mechanisms that are being looked at?
Or ultimately target something before the amyloid, like a metabolic shift in cell biology in the brain that may not even be neuronal.
And the whole thing will further transform as there are thousands of things being measured in the blood, whether it's the proteomics or the metabolomics and going across the trajectory of the disease and before the disease. So I think A-beta and tau are exemplification of important observation, much more to come. So the debate is open. I think it will become even more open. Right?
So with regard to disparities, Tommy, when we go into these populations that aren't the super phenotype, deeply phenotype specialized populations, and I completely agree with you that that's what we need. What will we be using as our gold standard?
That's the problem.
Yeah.
So back to like the natural history studies that you're proposing, which is really going to be needed. I think like at this point, people shy away, and I would also, I'm very much interested in the mechanisms and what really drives aspect. But I imagine like that study, what would be a goalpost? Maybe we should look at some like natural, like really no a priori assumptions. Do a lot of like omics-based approaches, proteomics, genetics, and then follow these individuals. Mm-hmm. Don't expect anything because you don't have any cognitive change at that point. Maybe you're looking at them from 30s, just keep following them. And there are studies like that. Some did collect blood and then they're banked. Just follow them, look at the changes of anything that you want to look at. And then go into like when they're in their 60s or about, and then which of them developed these changes? Could you track it back to all the measures that you had when they were decades before? And is there anything predicted?
Yes.
The only way we're able to do that, following what it really tells us. There are some studies, for example, that we have that are more similar to this, but then they don't have imaging or CSF. And we are always quite careful the way we write papers about that and they're beautiful because they focus like about 2,000 people. This might have study where the only individuals who were unimpaired at baseline were included. These are community-based cohorts. And then they've been followed for like 2,000 years. But the focus was cognition. We can look at what is like when people take over cognitively, but then we cannot also say what it links back. So those are some of those things. And then in terms of like these population-based studies aspects, it's going to be difficult to really know some of the things we have to factor in. I think these comorbidity aspects are difficult, but I didn't show that here. But for example, we've shown that when you take like phosphatile to this brain-to-reptile ratio, in addition to all the other ones I showed, in individuals who have stroke, those who have TBI, those who have Creutzfeldt-Jakob's disease, where you see increase in phosphatile, when you take those ratios, they normalize everything. There's only those who have Alzheimer's that stay at. So in a way, we're actually getting close to being able to find ways of being able to tell what measures are very much aligned with Alzheimer's from an Alzheimer's amyloid perspective.